I'm a pediatric critical care doctor, pediatrician, internal medicine doctor, pediatric fellowship director. And today I'll be talking about the successes and barriers in utilizing real-world evidence in assessing the outcomes of pediatric diseases. The objectives of this talk are to describe an approach to apply real-world evidence to pediatric medicine, or at least how I do it. Discuss the strengths of this approach, understand the barriers that exist, and discuss the opportunities for others, particularly non-coders, such as myself, to formulate their own approach. Some disclosures: I received funding from the New England Journal of Medicine for educational materials and content. I have no expertise in computer science, and what I mean by that is I don't have a master's. I don't have a degree in a bachelor's of science degree in computer science or anything like that. And before 2020, I was only a Microsoft Excel master, if you know what I'm talking about. You're an Exceller. Some background to provide some perspectives of where I am coming from. There are pediatric diseases, and studies do exist examining these diseases, but the number of subjects enrolled continue to be small. In this paper, the diagnosis, treatment, and outcomes in children with congenital nephrogenic diabetes insipidus, the Pediatric Nephrology Research Consortium are trying to determine how clinicians approach congenital nephrogenic DI. They also wanted to determine long-term outcomes and prognosis. These patients are incapable of concentrating urine, leading to discharge of large volume of unconcentrated urine, which can cause things like dehydration. And when it occurs long-term, and if it's unrecognized, and if it continues to be unrecognized without proper treatment, it could ultimately cause damage to the kidney and impact developmental and growth issues. So early diagnosis and treatment is therefore recommended. As parents of these children, they often request information about prognosis and future renal outcomes. So this study was timely. So in this study, they recruited 16 centers and they enrolled about 60 subjects. And from this data, which was a retrospective chart review, so that means they got the data and then they went into the chart to review everything, they determined that a significant proportion of children have persistent short stature or underweight, have adverse events, including like hospitalizations, urologic complications, and kidney damage, like I mentioned. While the findings are important, there were only 60 subjects. So the study was underpowered, and a prime example that there are not as many children as adults when trying to evaluate important questions such as this. So childhood diseases are rare, which is good. That means a lot of our pediatric patients are healthy. But what happens when a child is not healthy? What happens when we do not know? And what if we do not have the data to treat these patients safely, effectively, in an acute and a long-term fashion? I'm not going to use this talk to argue that using real-world evidence like Trinetics will solve this issue, but I think it's a great start. So for example, this is a screenshot using the Trinetics platform. I took a similar approach to the Pediatric Nephrology Research Consortium and evaluated congenital nephrogenic DI. So I queried the database, ensured the subjects were aged 21 years or less, similar to that study I just described. I queried, and first I looked just to see how many patients were available and from how many centers. As you can see, 606 patients were available to be reviewed, compared to the 60 subjects in the last slide. And data came from 45 centers compared to the 16 centers from that previous study. When they took a deeper dive, the demographics were similar, but the mean age was slightly different. Well, majorly different. The mean age was 12 here, while 4 years old in that other study. I did dig a little deeper to look at some of the more important outcomes that were looked at in the aforementioned study. And the frequency of chronic kidney disease or kidney damage was similar. But they reported about 32% had failure to thrive or growth issues, while when I looked at the diagnostic codes here, 45% were reported to have failure to thrive. So I bet you're wondering, does this tell us anything more? Or maybe you're wondering what congenital nephrogenic DI is, because I don't think I explained it that well. It's hard to say for sure if this is going to help, but I think it may help. And I think it does strengthen the findings of that smaller study. We do not know which healthcare organizations contributed to this data because TrendX does not currently tell us, but we do know a lot of them are from academic centers. Even if they were not all from academic centers, these subjects, it is a bit concerning that almost half these children have failure to thrive. Could this mean that this disease is not identified early? Maybe it is not intervened in a timely fashion, but the treatments applied are not as effective as we think. This is all conjecture, of course. I'm not an expert in this disease. Also importantly, we can't put too much stock in a retrospective study using diagnostic code data. But the findings are potentially compelling. It does highlight a potential issue, at least for this disease. And maybe we as pediatricians need to be aware of this disease. And as clinician scientists, maybe that small study and this database study used together, we can figure out ways to improve the care of this underserved patient population. So that was a pediatric example. But I'm also a board certified internal medicine doc, and I do have experience in other adult disease processes. And sometimes I venture outside my primary specialty, just for fun. So during my time in both of these worlds, I've also identified areas where real world evidence can assist in answering questions for adults as well. So take this recent publication. I learned about this publication through Medscape. And also I received email alerts as well, so it was in both places. So when I get it from when I get this kind of information from two places, then I click on it usually. In this study or this case series, basically what's going on is that adults can develop atrial fibrillation, which causes an irregular heartbeat and can place the patient at risk for complications. So some can undergo an ablation, which you can scar the heart tissue and try to break up the electrical signals that are causing these electrical heartbeats and send them back to a regular rhythm and try to reduce the risk of thrombosis and stuff like that. So in this case series, the authors found that 6 patients out of 11,000 in their center developed tachycardia syndrome, which is a stress-induced cardiomyopathy. It is important to understand how often this syndrome occurs because it presents similarly to a heart attack, and the diagnostic treatment approach may be different. So same approach, I queried the Trinetics database, found about 138,000 subjects or so that underwent this procedure. And then I limited it to evaluate only those with stress-induced cardiomyopathy because a diagnostic code was available to actually enter that. And then I was able to limit the time period within 1 month after the procedure. So 56 had this disease. And if you look at the demographics, it appears that certain populations are at risk. So it seems like females develop this more than males. So a deeper dive in this, may be necessary. So in summary, the lack of understanding of the outcomes of various pediatric diseases and adult diseases, especially the rare ones, can limit the ability of clinicians to fully assess the quality of care provided. Certain pediatric conditions and outcomes are too rare to detect and study with any precision, even in large trials. And as you can see, real-world data collected outside of traditional randomized control trials can generate clinical evidence, but challenges exist. But first, let me discuss some opportunities. There is a lot of data that is extracted from electronic medical records, organized and mapped to this database. In real time, you can find and evaluate a disease if you know the diagnostic code, identify a time period, and evaluate the medications, procedures, and other diagnoses that were entered within that time frame. You can see what happens several days or months after the diagnosis, as long as they continue to be seen within the healthcare system. And if you feel like you cannot rely on the diagnostic code, you can use other means to try to identify your patient population. So here are a couple examples of my group's successes. One of the first studies that we did, we evaluated status asthmaticus in pediatric patients. There are specific diagnostic codes associated with it, And our thought was that this diagnostic code would not be utilized to describe a non-acute case or non-emergency case of an asthma attack. We did consider evaluating the use of certain medications just to confirm the diagnosis. For instance, like like a continuous nebulization of albuterol, which is how you would treat, status asthmaticus, one of the first-line therapies. But unfortunately, that granularity was not available. While the database could tell us the patient was on albuterol, we could not determine if it was continuously nebulized, nor the dose. Anyway, our question was a longitudinal question. So in subjects aged 2 to 18 years of age, can we identify subjects with status asthmaticus with a reported body mass index? And can we pull children who had a body mass index 5 years from the time of the initial status asthmaticus diagnosis? And what we found were that the overweight obese asthmatics have an increased odds of continuing to be overweight obese 5 years later. So this study reinforced the notion that when an asthmatic obese child presents with status asthmaticus, a thorough evaluation of nutrition, physical activity, and asthma control should be considered to try to reduce the risk of persistent obesity and possibly future asthma exacerbations. When I was in school, and by school, I mean high school, not really like medical school or any of the other schools that I had to go through. I remember some of my fellow students would set out for gym class, and this was like in the 90s and 2000s, for fear that they were going to have an asthma attack. They literally had, doctor's notes and stuff like that. And that's something that physicians did recommend. Some physicians did recommend at that time. While not recommended anymore, to this day, other study authors have reported that teachers, when surveyed, still believe that students with asthma should not engage in rigorous physical activity. While this may keep them safe from a respiratory standpoint, it may also decrease the quantity of physical activity and increase the likelihood that obesity develops. And in turn, may actually worsen their asthma symptoms and potentially cause respiratory issues down the line. So we published this in the Clinical Respiratory Journal. And from the time of data download to statistical analysis and acceptance, the time frame was about 5 months or so. So of course, I'm not advocating speed for the sake of producing quick scholarly output. In fact, I use studies like this now in a very paced fashion to teach medical students how to approach pediatric studies to evaluate clinical questions that were hard to evaluate before. But if you have a question and you feel it is impacting the care of your patients now, this tool can be used to highlight issues that were harder to do before and faster if necessary. For example, in December of 2020, I received a phone call from an outside hospital asking for assistance for a child in cardiac arrest. She was COVID-19 positive, and on heart imaging, it was found that she had a clot that obstructed flow from the right side of her heart to the rest of her body, and that caused her heart to stop. So without oxygenated blood flowing to the rest of her body, your heart will not function. In collaboration with this outside facility, we did everything we could, but we could not help her. During the aftermath, I learned that this patient was actually diagnosed with COVID-19 about a day or so prior to this incident. She also complained of chest pain, which, as anybody who has had COVID-19 knows, that is a common complaint. We'll never know for certain if high vigilance or emergency evaluation would have changed things, especially at a time when we were trying to tell people to stay away from the hospital. But you do have to wonder. So what we did was, my medical student and I, we looked up the medical literature and didn't see anything about children developing pulmonary embolism in this kind of acute fashion. So we queried the Trinetics database, and my medical student and I, Melissa Chimo, worked together to see if pulmonary embolisms occur in children with COVID-19, and to see if it is occurring, to try to highlight this issue with our colleagues, especially our critical care colleagues and emergency physician colleagues. While the numbers were thankfully small, in comparison to pulmonary embolism studies done prior to the pandemic, it did appear that it was occurring at a higher frequency, and perhaps high vigilance is warranted, at least at the time of the study. This is only one example of how using real-world evidence could highlight issues that we may not have been able to highlight before. This is a graph of RSV, or respiratory syncytial virus diagnostic codes. As you know, we're in the middle of an RSV surge, and all our children's hospitals are full with pediatric patients and stuff like that. In this study, this is a study that I worked on with my colleagues, Dr. Williams Thomas et al. What we were trying to figure out was we were trying to demonstrate the frequency of pre-COVID-19 pandemic RSV diagnoses and during the pandemic RSV diagnoses. So as you can see from this graph, pre-COVID, you can see the seasonality, like how it dips down in June and August and how it starts to increase in September, November, December. That was pre-pandemic. That's how these increased frequency and surges occurred pre-pandemic. And during the pandemic, because of social distancing and everything else, you can see how the diagnostic codes decreased to almost less than 10% or so. So I placed this figure here because, like I said, we're currently in a RSV crisis, and all the hospitals in the area have been near capacity. And the question that has been asked by multiple people are, could this have been known sooner? I don't know. The CDC does utilize a sampling strategy. So they use a small number of labs who report RSV positive data and have been able to predict the seasonality, at least pre-COVID pandemic. But in this particular instance, it was not effective in identifying a major outbreak in real time. And it costed us because we weren't able to prepare our hospital resources in a timely fashion. Maybe we could have, canceled all ours. Maybe we could have done something to try to minimize the impact of this. And because the EHR is updated, frequently, including viral testing data, maybe we should have been considering using databases like Trinetics to identify these cases early, maybe help or prepare our hospitals for any RSV surges. So I spent a lot of time talking about the successes and opportunities of using real-world evidence in pediatric medicine. But the road to get here was a bit challenging. While I talk about my colleagues and medical students who are a huge help in finding literature, ensuring justification of these studies, and having the shared visions of highlighting disparities of healthcare, like this slide shows, where we evaluated critically ill children to see how often they had pregnancy screens, during their critical care admission, and where we found that it was not all subjects received a pregnancy screen, and it seemed like certain groups, like the Hispanic and Latino, the Hispanic and Latino population, seem to have a higher association with pregnancy screening compared to other groups. I'm primarily responsible for obtaining the data and wrangling it in a way that was understandable to a non-data-based person. So because of this responsibility, I would like to share what I've learned during this time. So first, you can only identify diseases with diagnostic codes. You can use laboratory results and maybe other means, but they are limited to results that indicate that the disease is clearly that disease. Like, for example, you can check for RSV positivity. So you could use the viral panel that the database provides to do that. Or if you check like a sodium level and the sodium level is like 119, you can use that value and say with reasonable certainty that that child or adult has hyponatremia. You will not be able to confirm the diagnosis, and there is no, as has been pointed out, there's no access currently to medical documentation. You're also relying on clinicians to enter the diagnostic codes, and you're also relying on clinicians to perform their usual history and physical examination. Basically, you're relying on clinicians to say, like, yes, this is RSV. And it's the same with procedure codes. The codes are very vast, and there are actually duplicate codes that are slightly different, but mean the exact same thing. So in this example, I took this sample from one of our recent studies. There are approximately like a dozen or so ways of saying that the patient is being basically the child is intubated and mechanically ventilated. So to get a true number, you have to data wrangle and characterize them and be sure to let the reader know, or whoever's reading your study know, that this is how you came up with these numbers. Longitudinal data is available, but only if the subject stays within the footprint of the EHR. If they seek care elsewhere, like at a non-trinetics institution, you may not get all the results, which may not be as impactful for an adult study, especially where some subjects have over 100,000 subjects. But it may not be impactful if you're working with like 600 subjects or so. Not all hospitals are represented. Certain data, such as race and ethnicity, is self-reported. And granularity may also be difficult to obtain. I already mentioned the medication administration and doses, but you will also not be able to get the time as it is not provided. You can get the date, but not the actual time. Thus, if I wanted to know how fast cefepime was administered from the time of diagnostic code entry to of sepsis to when the drug entered the patient's body, I want to be able to know that. Or if I wanted to know the very first creatinine level on the first day of critical care services, I can't. I have no idea which was the first value. I have to rely on using other methods like the maximum creatinine value, to see, just to try to get at, what's been going on with the patient's renal function. There's also a large quantity of data elements. Thus, you cannot rely on traditional means such as Excel to evaluate your data. So in 2020, Excel was all I knew. And when I first got the data set, and I've worked with database data sets before with the virtual PICU systems, they would send us data from multiple centers, and it would be organized, and I would be able to double click the Excel file, open it, and be able to see what I needed to see. When I first received the data set from Trinetics, I double clicked and I got the message, which I've never seen before in my life. And I had to actually Google to figure out what that meant. And basically I learned that Excel is limited to 1 million something 48, lines or something like that. And I was kind of like, okay. So then I Googled, what do I do when I have an Excel file that said file not loaded completely? And I got to this website called Stack Overflow, and one of the people who write message so Stack Overflow is this place that you can go to if you have a question about programming or Excel or whatever. And there are these people who do this stuff all the time. If you ask them a question, you provide them an example, they'll give you a solution that can potentially work with your whatever your question is or whatever. So I guess somebody had asked this question before, and I just remember this person wrote this really snide comment, you can't use Excel for this, you have to use Python. And I was kind of like, what's Python? So then I looked into it and I was like, oh, there's an easier way of loading this data. So I basically went on YouTube, looked up Python, and found this very young person. I believe he had to be 14 years of age, who basically described what Python was and gave these simple directions to show how easy it was to use, and used a Pokemon data set, if you guys know what Pokemon is. So he used a Pokemon data set, and I was able to work with him on YouTube and be like, oh, so this is how you load the data frame. This is how you extract whatever you need to extract. This is how you find the Pokemon cards with the higher power. So Pokemon cards have different powers, and some Pokemons are more powerful than others. So I figured out how to extract and extract and make it a known file. So anyway, so sorry, I get excited when I talk about, this YouTube video, because it set me forth on this path to, figure out how to work with this data and everything. But anyway, I use Python, and now I'm starting to learn how to use R as well, to data wrangle essentially. Currently without the help of an expert data scientist. So I'm using it now to ensure that the code is not, so I'm not counting the same code twice, because like I said, there are duplicate codes and stuff like that. I also know how to extract from the time period that we are evaluating, so that we are only focusing on the time period when the conditioning occurs and not later. yeah, so there's that. Oh, next slide. Finally, to my knowledge, there currently seems to be like a lack of validation studies. I look every once in a while in PubMed, and I do talk to my colleagues in other institutions who are critical care. Adam from Rochester is working on this. So they are evaluating the probability that subject evaluated as a condition. So they're trying to evaluate the probability that using the data that these databases like Trinetics generates, what's the probability that is actually examining the condition that we are evaluating or so. Now, while there are no current studies right now, based on my experimental knowledge of working with the data, there seems to be things that you can do to ensure that you're like looking at like the right groups, to at least reassure yourself and the reader and your colleagues, especially if you're making if you're trying to make an association, like this could be a problem or this could be a potential, future research issue that we could, look into or whatever. So like, for example, like I'm currently working with medical students who are interested in OB/GYN and anesthesia. They had an interest in identifying patients with who develop complications from preeclampsia. So they asked for my help. So I said, okay, well, let's see what we can do with Trinetics or whatever. So I queried Trinetics, pulled the data, and we used the diagnostic codes where clinicians diagnose preeclampsia. And then to ensure that the patient, to increase the probability that the patient actually had it, I also extracted and mapped the administration of magnesium, and mapped it to these patients, and it only included those patients with a preeclampsia diagnosis and basically magnesium, who received the drug magnesium, and basically said, well, we can't say for certain that these pregnant adult patients had preeclampsia. We can say that the probability is much higher because they've had these things. It's not perfect, but it does kind of reassure us, especially when we look at the outcome data. It does seem pretty consistent especially with the research question. So we were looking at this hyponatremia, low sodium predicts complications from preeclampsia, and we did it in a retrospective fashion or whatever. And then when we looked at the hyponatremia group, there seemed to be like a higher frequency of certain things like urgent C-sections, that sort of thing. That could be important for that underserved patient population, pregnant women. So the future. So physician scientists may not have a deep understanding of how to approach data science. So we must develop connections with experts in this field. So we need to collaborate with these experts to evaluate if the questions formulated can be answered. So while it was fun to code and fun to self-teach and fun to stimulate, things in my brain, because as you grow older and stuff like that, you probably should continue stimulating your brain and stuff like that, to grow as a person and such. It takes a lot of time, you also have to use it in a fashion. The knowledge that you gain, you have to use it in a fashion that like has to work seamlessly with your research question. So you can't like act like a clinician 1 minute and then act like a data scientist the next minute. It has to like merge together and integrate, and it takes a lot of work to integrate those words with those two worlds. And I don't know about you all, but when you try to integrate things together like this that seem to come from two different areas, like it gives me a headache sometimes. So my life would be a lot easier if I can formulate a question, query the data, maybe get the data, and then maybe communicate with a person who's dedicated their life to programming in a language they understand, organize the data in a way that is understandable. So like, for example, like I wish I had a person who just, all they do is data, and I can say, hey, I have 1,000 subjects with procalcitonin levels, which we check for bacterial, to see if there's a bacterial infection, essentially. So I have 1,000 patients, and I have all these procalcitonin levels that we got on day 0 of hospitalization, or at least we think is day 0 of hospitalization, day 0 of hospital billing codes. So can you remove the duplicate values? And if the patient has 2 values, can you just take the highest one, because that's probably the most important row? And then can you group them into a less than 0.5 and a more than 0.5, and then tell me how many of those were diagnosed with sepsis and renal failure, that'd be great. If I had somebody to work with like that, it would make my life a lot easier, because then I can focus on the clinical questions and not have to focus on figuring out how to write the code, which it seems like every single data set that I get, I have to think of like the code is pretty similar, but you have to modify it in a way that you do have to modify it slightly, because like it was mentioned previously, no data set is similar. So in conclusion, I love this work and I love what I do, so much so that I do it in my spare time, for free. It helps me teach medical students and possibly inform the public health of healthcare disparities that children face. And I hope that I piqued your interest. If you have any questions about getting started, please do not hesitate to reach out to me. I always have a few projects in the queue for medical students, such as that atrial fibrillation study query I just mentioned. I was Catherine from Trinetics and Omnish were able to get that data set to me very quickly. So I usually save those for medical students who are interested in research, so that we can work together to answer questions and to develop their research skills so that they can practice on their own and ask questions on their own. And maybe like my dream is that somebody does like so all these students I work with, they do database research first, and then start getting like interested in like certain clinical conditions and stuff like that. And then when they do their residency fellowship, and become attendings and stuff like that, that they become like prospective researchers, do multi-center studies and do randomized control studies and stuff like that. That would be that'd be my dream. I do have some acknowledgements. I need to thank Dr. Neil Thomas. He's my research mentor from pediatric critical care. Of course, I have to thank Omnish as well for exposing me to this. I also want to thank the biostatisticians from the CTSI who were very patient with me as I generate these data sets and then organize them and then ask them, can you help me analyze this in a fashion so I don't have to do everything all by myself. I do have help in some areas. Thank you so much.